This month we're going to talk about quality assurance auditing. We have to do it. It is part of the conditions of participation for certified agencies. And in reality, it is a necessary part of doing business. It shows us where we need to focus our attention to. We do have a number of quality assurance audits that we do. A lot of people think that they're utilization review audits only, but there are a number of audits, and I'll explain that further as we go along. Quality in real time was formed 6 years ago. I have been a home care nurse for about 42 years now. I've held every position in home care agencies that there is to hold. I had started approximately 9 agencies that are still they're still functioning as of today. But about 12 years ago, I decided to become a full-time consultant. And when I went out on consulting engagements across the country, I found that a lot of times I was called in because of issues related to quality assurance, either not being done or being on a back burner, and agencies developed issues very quickly. So 6 years ago, I formed Quality in Real Time to put some quality assurance items under one roof. And what drives us in Quality in Real Time is our customer service and exceeding the deliverables of the customer. We are a pretty lean organization. We have a board of directors. I am the president and chief executive officer of the company. We have a chief operating officer who handles human resources, information systems, computer systems, and our billing. And we have a chief clinical officer who oversees our auditors, our coders, our reviewers, and oversees our quality oversight. So our culture is one of collaboration, creativity, and accountability. When I worked in community health, I sort of did not like, as an executive, just receiving a report. I wanted to talk with people who did the report. I wanted to see what their findings were, and I wanted to see if they could offer us any solutions to our problems. But within our own culture, accountability is key. Everybody has a job to do, and we have time frames to do it in, and we hold true to those time frames. And in reality, over the course of my career, I have been in touch with many people and have followed a lot of them because I enjoy them and see that they have very good credentials and abilities. And so I believe that Quality in Real Time has attracted the best and the brightest, so to speak, in all kinds of auditors that we have. Being that we are a quality assurance organization, we have the ability to collect the data and use that data to connect clinical and financial goals so that we can support the organization to make evidence-based decisions. And this assists organizations tremendously if they have the data available to them as to the reason why they chose to do something that way. And again, we assist our customers to reduce the variability in clinical processes. We've assisted customers in developing forms that allow clinicians to answer the same thing the same way and not have 20 different interpretations. We've also looked at agencies' forms. One of the things with agencies is they tend to develop forms in response to corrective action plans, either by a survey or accreditation process, and they add those forms to the forms they already use. So sometimes there's a pile of forms, and everything should be looked at, and we assist the organization to look at the whole process and to see the easiest way and the best way and best practice way to do something. And we can actually predict to the organization or to assist the organization to manage patient-related risk. A lot of this has to do with potentially avoidable events, adverse events. So with our data collection tools, we can look at the reasons why something happened, and we can assist the agency to develop a risk management program out of that. Because of my background in community health, we really are operationally, clinically, and quality management driven. We employ experts. All of our auditors are credentialed. They are either certified coders, they're certified OASIS reviewers, they are hospice quality assurance reviewers. We have people who are ADR experts. We also have people who review and do quality assurance audits who have done this for over 20 years. We provide reports and analysis to the organization. We just do not give them the outcomes of audits. We do an analysis of the outcomes, and I personally put together a report looking at the strengths and the challenges for an organization and working with the organization then post-audit to develop a corrective action plan and then following that through. And we also provide consultative interventions if necessary. So we have a cadre of credentialed professionals, as I spoke of, under our roof. We have personnel now from 42 states who work for us. We have over 100 auditors now working for us. They have multiple years of experience. I wouldn't even want to add it up, but I would suspect it will come over. It would come close to or perhaps over 1,000 years of experience. And a number of our auditors also have expertise in ADR response, which is an increasing line of auditing that we do. Okay, these are the types of quality assurance audits that should be done in an organization. Whether we do it or you do it, I always think that these types of audits are really the minimum necessary to do. And you don't have to do a lot of audits. I can tell you that while the condition of participation on the QA audit does have a minimum number or a percentage number of the census to be done, all of the other audits in here, really within the first few audits, you probably can see a trend happening. Just to go through these rapidly, eligibility audits. These are done to make sure that the client meets the beneficiary definition of eligibility. We do these a lot on hospice patients. We want to make sure their primary diagnosis is supported by documentation that meets the LCDs or local coverage determinations. We want to make sure in eligibility audits that if the patient is receiving services and is a Medicare beneficiary, that we have a verbal order for services, that a doctor has received the plan of care, that we have a face-to-face, and that the patient has a documented homebound status. Then we move in, of course, to the documentation supporting the need and reasonableness of home care services. Pre-bill audit, so eligibility audits are done in the beginning or the start of care. Pre-bill audits are done at the end of care before you drop the final bill. And we do these on all types of payers, and it is a look at the 60-day care episode that is done to make sure, again, documentation supports all of the eligibility requirements and also the services that were given, and that those services have documentation that support their reasonableness and necessity of the visits that were made. QA audits are done quarterly. They're quality assurance audits. They could be called utilization review audits, depending. These are audits that are pretty intensive. The conditions of participation is that you do 10% of the census quarterly or a minimum of 20 charts quarterly. You review them for compliance with the conditions of participation and any other questions that you might want to ask in the audit. If you're accredited either with CHAP, Joint Commission, ACHC, you might want to put some standards in those types of audits. I often talk about audits being broken down. You can break down audits as far as you want to include down to the clinician level. So you could have a branch, a team, and a clinician on that team. And you should take audits, probably when you do break down, the census report should be broken down at the minimum of teams or programs. Focused audits are usually done, we see them done on a program or a manager, and these are audits that are just focused on that one area. ADR review, we do a technical and documentation review on a worksheet related to when we get an ADR, we look at that, that chart, and we make sure the documentation is as robust as it can be to support the need for services. And of course, with ADR review, you have to make it through the technical end of ADR review. So you must have signed doctor's orders, you must have a verbal order date, you must have a face-to-face. If they deny you on the technical end, they will not even look at your documentation. So they look very closely on the technical end because it does cut down on the need for to review the documentation, which is more extensive. So I would urge all of you that when you send an ADR back, make sure you have all of the technical components in place with that ADR. Personnel audits, we do a number of these. There are a number of agencies who have gotten dinged on state surveys or during accreditation processes. We review the personnel files to make sure they meet the standards of the state that the agency is in, and also the conditions of participation are fairly broad, but we make sure that they meet it. Some states are highly regulated with personnel, and there are a lot of those charts. We want to make sure the process within the organization supports all of the personnel that travel through them, and then, you know, making sure the annual updates of any kind of inoculations and or forms that need to be filled out are completed and in the personnel file. It's a very easy area, excuse me, to get deficiencies in because it can fall behind very quickly. Documentation audits are very interesting. We started doing these as documentation to see if the documentation was robust. This type of audit has morphed into now a number of agencies utilize our review of this, of new staff. After 90 days, before they take them off probation, a documentation audit is done on 25 charts from Nurse Mary to make sure the documentation of that episode, that there's a story told, that there's reasonable and necessary, that there's coordination of services. And for a number of agencies, they have set the parameter of what that person needs to score on an overall compliance level to be taken off of probation. There are a number of states where once someone is taken off probation, it becomes much more difficult to terminate somebody, whereas prior or being on probation, it becomes much easier. And as we all know, documentation is key in home health. It's one thing to go and do a visit. It's one thing to sit in an office and document coordination. However, if the documentation is not done or not done correctly, the reimbursement will not come to you. So these have been proven to be, agencies have come back to us and have told us how important this type of audit is to them. So we do a fair amount of these audits on an ongoing basis. So again, to reiterate, the QA audits are done quarterly on a percentage of census for the PAC and board information. They're required for the conditions of participation, but I really look to these audits to give the agency a focus for potential PI projects. Agencies at times have difficulty developing PI projects, and there should not be a lot of PI projects every year. There should be maybe 2 or 3 at the very most. But I think if you develop PI projects, they should be important to that particular agency. And I look to these QA audits to do that, and have seen over the course of time very successful outcomes from PI projects, and the agency maintains their gains they've made during that. Now again, QA audits, 10% of the census or a minimum of 20 charts quarterly have to be reviewed. The outcomes have to be reported to the Professional Advisory Committee, and the Professional Advisory Committee must submit it to the Board of Directors. I do some of these QA audits for agencies, and I present to the board of directors through a webinar such as this during their meeting, and they are very appreciative of that. Again, ADR review, we have a worksheet, technical and documentation. We note discrepancies in documentation. We want to make sure the beneficiary is eligible for home care or hospice benefit on both the technical and documentation level, and we will give recommendations to put late addendums in to ensure that the documentation is robust to meet the ADR review. Eligibility audits, we want to make sure that clients are eligible for the hospice or home care benefit, and we want to make sure documentation supports the primary and comorbidities of the patient. Be very surprised how a number of times documentation doesn't mention the third diagnosis, which could be very important at all in all of the documentation. So it's really important to include a support of the diagnoses that you're listing as the reason or the focus of home care during that episode. And it could change episode to episode. And our pre-bill audits, we do these for clients prior to dropping the final wrap at the end of the episodes. We look at the documentation between the OASIS data points, want to make sure that that documentation supports that the diagnosis is skilled, intermittent, reasonable, and necessarily within compliance regulations, and that interventions were done, and we want to see the impact that home care services had on this particular patient. Most of the time it's very, very good, but there are a number of cases where we find either the patient has actually declined for no real reason or has held stable when we expected them to really increase their abilities. And at times we have found errors in the discharge OASIS that, if not caught, would lead to potentially avoidable events review and coming down on your reports. When we did a study a long time ago on adverse events, over 50% of adverse events documented were because a box was checked off incorrectly in the discharge OASIS. Usually we saw it under UTI or a fall that didn't occur. But people have to be very cognizant when they fill out the OASIS forms, because it is done on a logic, and if the documentation doesn't support the logic, it's flagged. Other audits. Our focused audits, a specific program, a specific team. We have a process. We did a couple of focused audits on the process. Was it followed within a program? That was very interesting, the audit, but we can do them on process too. Personnel audits, looking at the personnel file. Documentation audits done at the end of probation, or again, if there is an issue with staff, remember, data can help you make evidence-based decisions. So if we do a documentation audit on someone who's been there 10 years and we see the overall compliance is 65% on that documentation audit, then there's something that remediation either needs to be done or a decision needs to be reached by the agency. But it gives you data to back up your decision. Now, the way we do quality assurance audits, we develop questionnaires. We have a library of questions relating to many different areas, and we develop them, and then they are approved by the agency that we're going to do the audit for. If you are going to do audits, you need to also do that. You need to develop the questionnaire. You need approval. When you get approval from the agency, you get buy-in from the staff in terms of these questions. The questions that we have are related to conditions of participation, accrediting body standards, any state regulations that apply. But agencies also have asked us to place custom questions in. They want to see if something that they've taught or something that they do that nobody else does is reviewed, and is it in a certain place. and we will do that. We don't have a problem about that. We do review the point of care system with an agency clinician. We need to know where the information is found. And too many times we have found, and the agency has found, that they think the information is in one place. And in reality, the information can be in 2 or 3 or 4 places and is discovered because the auditor, the QA auditor, cannot find the information where that we were told. But actually, at times, the QA auditor, because they review a lot of documentation, finds it somewhere else. I would tell you that a CMS auditor or a state surveyor probably will not do the kind of overview and the looking at that we would do or that you would do. So if they can't find it pretty rapidly, they are going to say it's not here and that's it. So I would recommend to everyone that they have information that they want to document, that it is in a certain place, and every clinician goes to that place to document. We score our questionnaires by the individual question, and then we score it overall. And we can score it, again, by team, by clinician, and so on and so forth. We also see at times our auditors have comments, but there's no question that they can answer that relates to their comment. So we do have a place in our audit portal that we put comments in for, and when the report is generated, those comments are made available to the agency by the person, by the patient name being audited. So, and a lot of times some of the issues that come out in the comments are the ones that we see trends in, and our auditors will note that as a trend, that this is not filled out, this is not filled out. And once you see it 6 or 7 times, we have a trend. Now, this is the type of questionnaire that we have. So we have questions related to admissions. We have questions related to consent and eligibility, questions related to continuity of care. I'm sorry if this is not as clear as it could be, but putting this into the slide was the best we could do. But again, the question can be answered yes, no, or not applicable if it doesn't apply to the patient. But it's pretty much yes or no. And from there, we go down a list. Most of the questionnaires are at times they're 2 pages long, depending on the amount of questions that the agency wants asked. I haven't seen a questionnaire more than 2 pages long, however. And just know that each of these lines then is tallied, and then overall is tallied, and we can see that with the next slide. This is the type of reports that are issued to agencies when we do QA audits. So we can see, and we can carry it then across quarters, as you can see, if we're doing that, and the category of the question text itself, and then quarter 1 results, quarter 2 results. We do use a stoplight approach here in quality in real time. I have found over the course of time, talking with customers, this is what they like. So we have green, red, green, yellow, and then red. The customer makes the parameters. So 90 to 100 might be a green for one customer. Another customer would say 95 and above. Another customer 85 and above. But the customer gets to choose the parameters. What this shows over the course of time is what the agency either needs to pay attention to or what they have done very well at, and sees that they have maintained their gains. So on this one here, if we go down to the coordination of services, RN frequency in plan of care is followed. Well, the first quarter they had 70%. The second quarter, 45%. Well, you know, bells should go off in everyone's head. What happened? Now, it can be something as simple as that, you know, 2 RNs got really, really sick. We had real difficulty. But again, if you don't follow that frequency in your plan of care and you don't document why it's not followed, that is a problem. that any surveyor or any accrediting body will pick up on. There must have been some remediation because we went up to 57%, but it is still in the red zone, so more attention needs to be paid to it. Now, if we look at all of these, we can maybe pick out that maybe we might want to do a PI project based on the RN frequency and the plan of care is followed. Why isn't it followed? And that could be a PI project for the organization if they so chose to do that. So you can see how this works all the way through, and as I said, every line is totaled and percentaged, and then on the bottom, overall is percentaged also. We will drill down outcomes to customer specificity. If the customer just wants to stop at the team, that's fine. If they want to drill down to clinician, we will do that also. I caution people, if you drill down, you have to have a big enough sample so that one chart, if it's not done, doesn't throw you way down the list. So I'm thinking of if there's only 2 charts, and one is yes and one is no, you automatically have a 50% compliance rate. So again, I urge you to have a big enough sample size. An analysis report, again, I talk about strengths and challenges to an organization and recommendations. We look at key findings and we give key recommendations. So we identify trends. The agency can focus on them with either education or perhaps a PI project. Individual focus on problems that may be in one place and not another. I cannot tell you how many audits we find Team 1 is phenomenal on doing certain things and not so good on others, and Team 2 is the absolute opposite. But if we try and put everybody into the same category, we're not focusing on that particular team or particular problems that a team might have. We have our value added here is that we can get agencies off of targeted medical review or not allow them to go on targeted medical review after probe audits. I've had a number of agencies contact me after the first probe audit. We did a second audit, a third audit, and then showed them where their documentation was problematic. And by the time they got the request for the second probe audit, they had corrected some issues. So they didn't go on TMR because they did so well on that second audit. Again, needs within an agency, comments. This is not being done on 7 out of 10 charts. There's an issue here. You might want to look at that. So we notify the agency of the need, and then the agency is made aware in a proactive manner so they're not reacting to something when it comes to fruition. And I think some of our audits provide good bookends so that, you know, the agency can concentrate on the documentation, because that's what we really concentrate on in the quality assurance audits, is the documentation in the middle, telling the story. Why is quality in real-time called? Well, we get a lot of calls from the chairmen of boards of directors, and they want a one-time-a-year quality assurance audit by an outside company just to see. They want an outside opinion. I think it's a very good idea, and I think that they're on the right track when they do this. We're called after a survey because the corrective action plan calls for an outside reviewer. This is becoming more and more common in states where the Department of Health or whoever does your review wants to see outside reviews. They really, this is what they go for. And we have done audits for every month for a year for some agencies because that's what the corrective action plan wanted. And again, there are times when an agency wants to place their resources towards another crucial area and they want to outsource the entire QA process. For some newer agencies, instead of utilizing QA personnel within the agency, they put their dollars towards marketing or advertising or something like that, and outsourced the entire QA process to quality in real time. Not necessary, but for some agencies, that's what works. So the benefits of quality in real time, I believe we have very competitive pricing on our audits. We are all about quality outcomes. I think it gives a peace of mind to an agency, and I've heard that from more than one chief executive officer. And again, we are about collaboration and expert opinion, and we'll work with an agency to assist them through this process. Someone once told me that quality is painful at times, and I agree with them. Nobody likes to be told that, this is not really the way you should be doing it. But after correction, everybody agrees that they needed to have done that.
Laura, amazing job as usual in explaining the importance of quality assurance audits. Thank you very much for that. As a reminder, you can join us online again for Laura's Part 3 of 3, the Community Health Education, on Tuesday, June 19th at 11 a.m. You can also register for this webinar from the GLMI website, from the calendar on the training tab, and we're also going to be sending out, as we did before, another email reminder that will contain the registration link as well. And as another reminder, all of these expert webinars, so if you've missed any of Laura's past webinar or her past webinar, Part 1, you can always watch the YouTube channel, the GLMI YouTube channel, and check it out there. So if you missed an earlier expert webinar, whether it be this one or any past ones, they're all out there and on the YouTube channel. So you can go out there and they're available for you. So right now I'm going to open up things for questions for Laura. So if you have any questions, go ahead and type them in on the right-hand side, the questions area on your webinar control panel. I'll go ahead and give you a few minutes there to assemble some questions. And Laura, I'll go ahead and just read those off to you.
Okay.
Get them. First question I think is directed more towards me is, would it be possible to get a copy of the PowerPoint presentation? Also for Part 3, would it be possible to get a copy to print to add notes to prior to the actual webinar? To answer question number 1, yes, the email will be going out immediately after this presentation concludes, and it's going to have the link to the YouTube channel as well as the link to the PDF of this PowerPoint presentation. And to answer your second question, will it be possible to actually have one in advance? Yes, we'll make sure that we actually work towards getting you an advance copy prior to today's webinar. All right, any other questions for Laura at this time? This is not your parting shot, so if you have a question after you hang up, that's usually what happens to me. I hang up the phone, and I get about 5 questions that pop into my head. Laura's information, contact information is on the screen, as well as my contact information. So if you have any questions for either one of us after the fact regarding this or any of the other previous webinars, please feel free to contact us anytime. Laura, do you have anything to add before we conclude the webinar?
No, I really don't, Art. I want to thank you for the opportunity to present this. Quality assurance is not something that a lot of people present, so I think it's very helpful to people to be able to get this information. And everybody should feel free to email me if they have any questions about quality assurance.
Okay, great. Okay, I guess that concludes our expert webinar. Laura, excellent job, and thank you for your time and expertise. I know we're all looking forward to your expert insight again next month. So join again next month, and we'll looking forward to that. So thanks again, Laura.
Thank you. Thank you.
All right, have a great day, guys.